We are going to give a few minutes for people to trickle in, and then we will begin. All right, I think it's a good time to get started. People can join as they do. I'm Lauren Cardoso. I am one of the deputy directors of our Office of Statistics and Evaluation in the Bureau of Community Health and Prevention at DPH, and have been one of the principal investigators on the COVID Community Impact Survey for the last 2.5 years. I'm really grateful to have everyone here to hear this presentation. We've been working on CCIS since the beginning of the pandemic, and are now, or have been at least in the last few months, in a kind of reflection period, looking back on what we did with CCIS, how we did it, what we did well, and where sort of the impact was, and how do we take the lessons that we've learned from this work and carry it forward into a continued effort to do health equity focused data collection with the sort of intentionality that we did with CCIS, and really codify that in our data collection and data surveillance going forward. So I'm excited to share what we've learned in this process and where we're headed. And yeah, I'm excited to just have everyone here together. So the way we'll do this is I'll go through the presentation. Feel free, if you have questions as I go, to ask them in the chat. We have a number of CCIS team members who are here today who can either answer your questions in the chat as we go, or we'll hold on to those questions and we can answer them sort of in a group after I finish the presentation. And then we should have plenty of time for question and answer. If you have additional questions, you're certainly welcome when I'm done to come off mute and we can have discussion. And we also have some questions to pose to you, the audience, as we start to, again, continue to think about what the next phase of this work looks like. So I'm just going to jump right in. So we've done dozens and dozens of CCIS presentations, and we always start by acknowledging the massive amount of people who have contributed to really making CCIS a successful effort. This is just a fraction of the people within DPH who really helped us put this work together from start to finish. But we also have a number of community partners who were really essential in us reaching populations that we knew were being disproportionately impacted by the pandemic, to get them to participate in the survey and help them tell their story and raise their voice about what their experiences during the pandemic really were. So the community partners were essential, and I'll talk more about that as I go through this presentation. So just as a reminder, I mean, some of you on the call probably have seen me talk about CCIS, and for those of you who are new, I'm going to just kind of refresh a little bit about where we were when we started this survey. And so, we first started talking about it immediately in March of 2020, when we really started to see and understand that the pandemic was disproportionately impacting certain populations that we knew were not well represented in our health surveillance, our traditional health surveillance. And so we really wanted to think about how we can collect information that would help illustrate the needs and help us address the needs of these populations. And again, with the specific intention of always taking action, right? We wanted to do a survey where we could collect information that was actionable, both to DPH and to our partners, and not just collect information just to learn, but really to be able to do something about it. And so again, knowing that our health surveillance wouldn't be able to capture the experiences of a lot of the populations that we knew were being disproportionately impacted, we had to come up with a new effort to collect data from these populations in particular. And so some of the things that we've identified that we knew would be important in how we did this included creating a data system or a data collection effort that was timely and nimble enough to capture emerging health needs. And so what that means is, like, typically, with our health surveillance, we might collect data and not actually be able to analyze it or do anything with the data for a number of years. And with CCIS, we knew it had to be different. We knew that we had to put the survey out, do the analysis really fast, and be able to share the results quickly enough to actually take action. And so in the case of CCIS, we fielded the survey in the fall of 2020, and we're able to share results by December of 2020. We also knew that whatever information we collected needed to be detailed enough to not just tell us about outcomes, but actually like root causes of the inequities that we were seeing. So for instance, we didn't want to just be able to address outcomes, but really what is driving these outcomes? How do we get to the thing that's causing people, for instance, to have poor mental health outcomes? So we know, if we know that people are experiencing poor mental health, certainly we need more access to mental health services, but there's reasons why folks are experiencing poor mental health. So we really wanted to be able to create a survey that could capture some of those root causes. We wanted it to be granular enough to tell us how to tailor efforts to specific geographies and specific populations. And so one of the challenges that we constantly meet with our traditional health surveillance is that sample sizes of some populations are so small that we can't say much about their experience. And so with CCIS, we wanted to really do things differently and make sure that we were able to understand the unique experiences of very specific populations and not have to tell a broad story, but really tell a very specific one. And I'll give some examples of how we were able to do that later in the presentation. And then cross-cutting enough to inform how different parts of the department and different community organizations could work together because of how certain issues intersect. And that way we could better coordinate our efforts to address the issues that people were facing. And so this is a little bit on how we did it. Again, for those of you who may not have seen this before, we conducted again a survey in the fall of 2020. We had over 33,000 adult respondents and 3,000 youth respondents in our final sample. For a number of these groups, we also did population-specific focus groups. We did them in 2 periods of time. One was in December of 2020, and then we did some last summer. The survey itself covered a wide range of topics specific to youth and adults. Some of these included perceptions and experiences of COVID-19, people's ability to meet their basic needs, their access to healthcare, pandemic-related changes in employment, and then the impact on mental health, substance use, and people's experiences of violence and safety. The survey was available in 11 languages, and additional focus groups were conducted in American Sign Language. The survey had a number, it was a long survey, had a lot of questions, including open-ended questions that allowed us to capture previously unknown needs and barriers, things that were very specific to the pandemic that we just couldn't even anticipate. The results were weighted to state averages, and that was true for both youth and adults, so they were weighted differently. We recruited again via a network of community-based organizations. So we really relied on dozens of community-based organizations who served the populations that we knew were being disproportionately impacted to help recruit folks to take the survey. And this was one of the most important partnerships that we created in this process in order to make this a success. And this recruitment strategy also included a snowball sampling strategy, which allowed us to continue to reach the key populations that we were hoping would take the survey. And some of these key populations included people of color, LGBTQ+ individuals, people with disabilities, essential workers, people experiencing housing instability, older adults, and individuals living in the areas of the state that were hardest hit by COVID-19. So some of the things that we think were imperative in our ability to actually do this work well from a data perspective, included community engagement at every point. So, we really did work with community-based partners from when we were designing the survey and piloting questions and trying to understand people's perceptions of what we were asking and what people's needs were, to how we interpret the analysis, how we disseminate the analysis, how we tell the story so that it accurately reflects the experiences of the communities represented in the survey. And so again, we baked community engagement in at every point, and we think that was a really important part of our process and one that we hope to replicate moving forward. Developing this sampling approach and a weighting approach that helps us, again, tell us a granular story about the inequitable experiences of populations across the state, using mixed methods. So, the survey had a lot of rich data, but being able to pair that with more narrative data from focus groups helps tell a more nuanced story about what folks really experienced during the pandemic, and continue to experience. I don't want to talk about the pandemic as though it's past tense. And so, being mixed methods really did give us, again, just like an extra level of nuance that we think is important when you're trying to tell an accurate story about what people have experienced and what their needs are. And then being population focused as opposed to condition focused helped us orient around populations and people and their experiences. So making sure that the questions reflect the experiences of the people we're trying to reach, that our dissemination strategies reflect how folks would access a survey, as opposed to thinking first about the outcomes we're trying to understand. Our sort of strategy was more focused around making sure that we were thinking first about the populations we were trying to reach. And so these were some of what we think are innovations in our data collection that helped us really tell a story about the inequities that were experienced during the pandemic. But in addition to the data piece, there's also the action piece that to us was equally as important. And there were some things that we did differently from this perspective that I think are worth highlighting. So we built in action work streams to our work. So there were a number of epidemiologists who are, really leading this work. And so the action piece is not typically in our wheelhouse. So what we did was try to identify decision makers, identify programmatic groups, identify community-based partners who we can feed the data to so that they can make change and use the data in a quick and actionable way, as opposed to us just putting out results, which is what an epidemiologist typically would do. In this case, we were really thoughtful about making connections with groups who could actually take action with the data that we had. We also, if you've seen any of our presentations or have been on our website, and I'll share information on how you can do that if you haven't already. We built racial and social justice framing into all of our presentations to make sure that when we're telling the story of the inequities that were experienced as a result of the pandemic, that we point to the systems of oppression and the inequity and the inequities that are driving the disparities that we're seeing, so that people can think about root causes when they're thinking about, and so how do we take action on XYZ thing? Well, here are the systems of oppression that are really driving these inequities, and here's the language that we share so that you can really understand that this isn't specific to the pandemic. These are things that have been existing for a long time, but the pandemic has exacerbated these inequities. Again, building in community engagement into the action component of this research was really important. So making sure we were doing presentations, that we were sharing data back with the community, we're making data as accessible as quickly as possible so people could use it to change programming, to write grants, to really understand better what was happening in their community and what the needs of their community, what the needs were, was something that was really important to us. And then again, thinking about these root causes. So not just the what has happened, but who it's happened to and why. So, making sure that we're sharing that information. So again, we're pointing back to like, how should folks be addressing these issues? It shouldn't always be just looking specifically at the outcomes, but what really is driving these inequities and who are experiencing the worst inequities. So that was part of how we wanted to present the information and share the information and disseminate the information so that folks could actually do something with all of this research that we had been working on. And so, our reflection was really like, did it, over these last few months was, did it work? Like, we were very intentional and thoughtful about how we did things, but really, what can we say about the change that's happened because of CCIS? And so some of the things that I think are worth highlighting is first that, our sample size in and of itself was really unique. And, especially at DPH, this was probably one of the first times that we've had a survey capture these priority populations in the numbers that we were able to. So compared to past surveillance surveys, CCIS priority population samples reached 10 times as many Alaskan Native and Native Americans, 10 times as many LGBTQ respondents, 5 times as many residents who speak languages other than English, 5 times as many Hispanic residents, 5 times as many Asian residents, and over twice as many respondents in other populations, including deaf and hard of hearing and those in the Black community. And this is important, again, because it allowed us to tell a more nuanced story. We could actually tell a story about the experiences of Alaskan Native and Native Americans, which is not often the case with the data that we have. We're able to tell a story about the experiences of trans folks or the experiences of people who identify as non-binary. In our wildest imaginations, we would never have data to be able to tell that story. And by deliberately making sure that these are folks who were able to access the survey, we were actually able to do that kind of analysis. And that, to us, in and of itself, was a huge success. So this is some examples of key findings. They're not priorities by any means, but they kind of illustrate the importance of being able to tell those nuanced, granular stories that also point to root causes. And so I'm just going to highlight a couple of them. So for instance, one of the things we found was that Black and American Indian or Alaskan Native youth were 2 times as likely to lose someone close to them due to COVID-19 compared to all youth. And this obviously has huge implications for how we support young people, and was, one of the things that was critical in some of the procurements that were designed at DPH around how we support youth going forward. 1 in 5 Cambodian respondents lost their job. This is the second highest among all CCIS ethnic groups. Just the fact that we were able to look at ethnicity with that kind of granularity was unusual for health surveillance. And so in this case, if we had looked at a group, if we had looked at all Asians, for instance, as a monolithic group, we might have said, like, well, compared to other racial groups, they actually did quite well. But when you pull them apart and you look at actually the differences within ethnic groups within the Asian population, you can see that actually Cambodian Vietnamese populations had really, really high needs. And this allowed us to be able to be that specific about who needs help and what kind of help they need. American Indians, Alaskan Natives were 2.3 times as likely to worry about getting access to broadband than white non-Hispanic respondents. Obviously, especially in that first year of the pandemic, access to broadband meant access to school, it meant access to healthcare, it meant access to so many things, information that were important, and being able, again, to highlight that need in this population makes a difference in being able to address those needs that are so interconnected. Another thing we found, 70% of non-binary adults reported experiencing poor mental health for more than 15 days in the past month, and 84% of non-binary and queer youth reported feeling sad or hopeless for 2 or more weeks in the past year. I mean, the rates of mental health issues in these populations were so high. And again, being able to be specific about these populations allows targeted interventions to really support their specific needs. And I think the last one I'm going to share is that, we asked about racial discrimination during the pandemic and found that 1 in 4 Asian, multiracial, and Black respondents had experienced some form of racial discrimination during the pandemic. So just making sure to highlight that violence was an issue that certain populations were experiencing at elevated rates and really needed our attention, along with all of the other pandemic related consequences that we were dealing with. So again, I think that illustrates the importance of the way we did things and the way we were able to put a sample together that could help us tell these unique stories. And so we were able to share this out in lots of different ways that we hadn't really done before. This is was our attempt at quantifying all of the work that we've done over the last 2 years. And I'll just breeze through some of these things, but we have released probably more now than 26 reports of data. We've built an interactive dashboard that lives on our website. We have 25 recorded webinars that people can watch at any time that are on specific chapters of results. We've given more than 5 live webinars at this point. We've had 12 public presentations at our Public Health Council. We've had more than 30,000 views on our website. And on the right-hand side is kind of more of like who is involved, how many meetings we've had. It took a lot of work to get the data out there, but it was pretty unprecedented the way we were able to share this information, and particularly the rate at which we were able to share it. So this is a list of chapters of results that live on our website that anyone could access at any time. They both have PDFs of PowerPoints. They're accompanied by webinars that you can watch at any time. And then again, we have an interactive dashboard where you can actually dig into the data on a lot of these topics. I'm not going to go through and read these all, but I definitely urge folks to go to our website if you have interest in any of these topics. This is our website right here, mass.gov/COVID survey. And again, here you'll find complete slide decks, recorded webinars, data tables, a dashboard, and a Q&A document that actually pulls out some of the key findings of each chapter. So if you don't have time to watch a webinar, you don't have time to actually read through an entire PowerPoint, but you do want to understand a little bit about the experiences of, for instance, intimate partner violence during the pandemic, you can go to this document and you can see like 6 or 7 of the top key findings from those data presentations. So while having a sample that allowed us to tell these unique stories was important, being able to share this information in an unprecedented way was important. We really also wanted to look back and see, like, did other things change as a result of CCIS? And we had a number of conversations with folks who were trying to collect information about the difference that CCIS, these data mattered, that these data made over the last year and a half, either internally to DPH or externally with our partners. And these were some of the things that we found. So because CCIS was population focused, and we prioritized the inclusion of previously invisible populations. So for example, one of the things we were able to say is 48% of parents of youth and children with special health needs reported persistent poor mental health compared to 30% of other parents. One of our CCIS partners said, we have been data poor, relying on limited data sources with small sample sizes. The kids and families we serve have great needs and have been historically unseen and unheard. The CCIS has provided a rich resource for us to make smart, strategic, evidence-based decisions that can make a difference in their lives. So in this example, this group was able to share the needs of populations at the state level to inform policymaking, and in this case, elevating the need for respite care to be covered by Mass Health. Another example is, again, because we were population focused and we use data standards that are granular, inclusive, and reflective of populations' experiences. We heard that Mass Health is adopting the use of our rural definitions, that BMC's Pediatric Emergency Department is using CCIS's social determinants of health questions, and MAVEN now uses our sexual orientation and gender identity data standards. And so what this means is that way beyond CCIS, other entities are actually codifying equity in their data collection system. So by using questions that are reflective of how people identify and are very granular and are inclusive, it's really baking equity into how people understand the experiences of populations in all of these different data systems. So, in Mass Health, being able to think about different granular rural populations, in the pediatric ED at BMC, thinking about questions like food and housing as it relates to the health of their pediatric patients. And then again, using our SOGI data standards like really thinking about how we can tell a story about folks who identify as non-binary, which is different than the experiences of people who identify as transgender, or, you know, thinking about sexual orientation, and being able to really disaggregate in ways that are specific to how people identify themselves, means that just by sharing the way we did things, equity is being, there's like a domino effect in terms of how equity is going to be baked into other data systems. As another example, we again prioritize community engagement, particularly with historically marginalized communities. And one of the things we heard from a CCIS partner is Native Americans were once again visible in the data. The fact that CCIS connected the Bureau with tribal members to pilot and then took their feedback and brought that data back was important. And so this was just one example, but we heard several over the course of doing this kind of reflection, that we really, by being deliberate, by taking the time, and by including people in the process, we strengthened trust in DPH in communities where there was a history of distrust. And this is one of the things that we're, again, hoping to build on as we continue to bring CCIS into the future. Another thing that we found helped create change was because we were, again, nimble and able to share breaking needs data for prioritization, which again means, like, because we were able to turn things around really quickly. So one of the things that we illustrated was that people with disabilities face many unique barriers in accessing, for instance, information and services related to COVID risk mitigation. You know, we heard from one of our partners that with CCIS data in mind, our vaccine equity initiative prioritized improving vaccine access to people with disabilities. In the disability setting, people got vaccinated who wouldn't have because of CCIS data. You know, so VEI had access to certain types of data, but not data that actually disaggregated by disability status. And so CCIS was able to share with VEI the specific and unique barriers that people with disabilities would face in accessing vaccines, based on what we understood around the barriers they face in accessing other essential health services during the pandemic. And that gave them the information in the VEI team to make folks with disabilities a priority in getting vaccinations and coming up with ways to overcome the barriers that we were able to identify in the CCIS data. So this again is just one example of a way that initiatives could quickly pivot to meet the needs of priority populations. And we heard other examples of programs within DPH, for instance, that were able to get data from CCIS, see that there were actually needs in the populations that they serve that they were not aware of, that they could then pivot to help address in a quick way. And so one of the other things that we found was really important was our use of social justice framing. So the fact that we were able to talk about social justice when we released results that, again, drew the linkage between inequities and systemic drivers, empowered folks to really think about those kinds of root causes. And so one of the things that we heard was that health systems, municipalities, and other entities conducting health needs assessments and making improvement plans across the state told us that CCIS reports provided them with the evidence and the framing that they needed to prioritize these systemic drivers in their health assessments and associated funding allocations. So essentially, we were helping normalize the inclusion and naming of systemic drivers of inequities. For example, we talk a lot about structural racism, heterosexism, and ableism as health priorities. And because it's DPH who's doing this, it's giving other people and other entities in the state the kind of the freedom to do that themselves and to really bake it into their plans for how to address the health inequities, again, that are being exacerbated by the pandemic. So those were some of the key changes that we were able to capture that came as a result of CCIS data, both the data itself and our process for how we collected the data. You know, as we looked back, we obviously learned that we didn't do everything right, and that there were some lessons to be learned about how we could improve as we move forward with continued CCIS research. And so I just wanted to highlight a few of the things that we found were challenges and some of the ways that we're trying to address those challenges moving forward. So certainly time and human resource constraints within DPH was a huge issue at the time that we were fielding CCIS. So the original CCIS team were all folks who had other full-time jobs with responsibilities within DPH, and who, basically were doing this on top of their job. And so that is not a sustainable strategy. So we have been fortunate enough to be able to build a team now that's specifically dedicated to doing CCIS work, and a team that includes epidemiologists, community engagement specialists, communications, program coordinators, like top to bottom, building a team that will help us implement all of the things that we're hoping to do again, but better. Again, one of the challenges that we faced was inroads with some priority populations, but we worked really hard with community-based organizations to bridge some of those gaps, repair some of those relationships, and I think have set us up for a good sort of foundation moving ahead to continue to build on those relationships. Also, certainly no surprise to anyone on this call that at the time that we fielded the first survey, community-based organizations were also incredibly stretched thin, and I'm sure still are. But one of the strategies that was helpful was to be able to provide financial support where possible. So we gave stipends to community-based organizations to either pay for staff time or to use as incentives to recruit people to take the survey. And so to not just rely on people's goodwill or their even belief in the importance of CCIS, but really to honor their time and their human resources by giving financial support so that that time was compensated for. And I think that's something that we would continue to do going forward. Another challenge was distilling results into digestible formats. We had so many results and we were pushing out so much data so quickly that figuring out what was the best way to share data for certain populations or certain geographies or to certain audiences, there almost really wasn't the time to even think through it because we just wanted to get the data out fast. In our next phase of this work, as we can think about dissemination of the next survey and doing data analysis and dissemination of the results, our intention is to build a more deliberate and intentional communication strategy that has baked into it some more in community engagement to understand what is the best way, what are the best strategies for sharing information so that it has utility for people. We're aware that a PowerPoint presentation is not always the best way people want to receive information. No one really wants to read a 40-page PowerPoint presentation. And so we're trying to think through, and we'll continue to creative ways to share this information that actually has more meaning and utility for the populations that we're trying to reach. And then being fully accountable to partners. And what I mean by that is that we had a lot of people help us get this out, a lot of community partners that helped us get this out, a lot of different populations that we spent a lot of time engaging with so that we could tell the story of their experience during the pandemic. And being able to do the analysis and get all of that information back to all of those community partners, all of those populations, all of those geographies, all of those different audiences of folks was just nearly impossible. We just didn't have the time or the capacity to do it. And so in going forward, thinking about how do we make sure that whatever we commit to, it's feasible to go full circle. It's feasible to ask for folks to support this work and then report back to them with what they're expecting to see. So these are some of the things that are on our mind in terms of what was really challenging, some of which is really situated in the time that we were doing it, some of which remains to be a challenge. And how do we, build solutions into the plan so that we can do better as a team? And so I can say a little bit about, our work going forward. So now, we're taking these lessons, we're trying to create CCIS not as just a one-time survey that we did in a pandemic when we thought that was all it would be. It's like we needed data right then. we're going to do this survey, we're going to get it, and then hopefully we'll be out of a pandemic, and we can move on. But that's clearly not the world we live in. And so for us, what's really important is that we're trying to think about CCIS actually as a sustainable data system that continues to promote this idea of the importance of community engagement and data collection, data analysis, and data dissemination, that moves our work more upstream to talk about root causes and systems of oppression, and really centers health and racial equity, both within the context of the pandemic and, broader than that. And so, right now, again, we've been doing this reflection period where we are really trying to understand what we did well and where we can improve. We're continuing to build relationships with key partners, both external to DPH and within DPH, again, because community partners are super important as our decision makers within the state, so that the data is actionable. And then, with the goal to, again, build this sustainable data system that continues to rely on and build on the principles of racial and health equity, moving things upstream, and really being able to use data for action, all again with the hope to reduce health inequities, again, both specific to the pandemic and beyond. And so that is sort of what we've done and where we're going. And I hope that was a helpful sort of snapshot for some of you who are maybe coming to us for the first time, and those of you who've been part of CCIS for the last 2 years.